Hi, I'm Elise Schuman, and I'm the Senior Vice President for Health and Paid Leave Policy at the American Benefits Council. And I have the pleasure of introducing our speaker for our pop-up session on paid leave. We heard earlier about the Wild West of the world of employee benefits 50 years ago before the enactment of ERISA. And now we're going to hear from Josh about the Wild West of paid leave benefits now, particularly as more and more states and localities enact their own paid leave laws in the vacuum created by the lack of federal legislation. So Josh is a partner from the law firm Seyfarth Shaw from New York and a real expert on paid leave. So we're thrilled to have him join us today. Josh?
Hey, thanks, Elise. Hi, everyone. Great to be here with you this afternoon. It's a pleasure seeing you all. Love coming down to DC for these events and conferences. This is my first one with EBRI. I work with the American Benefits Council fairly regularly on their paid leave priorities and strategies. I'm really happy to be here with you for these few minutes today on the pop-up talk on paid leave. So have three main topics I'm going to be covering. The first is just to give everyone a lay of the landscape on both state and local paid sick leave laws, and then separately paid family medical leave laws to see what happens when preemption and harmonization and equivalency doesn't exist. Then we'll talk very briefly about what some of those challenges are for employers and their employees when you have a patchwork of laws scattered around the states and those laws diverge from one another in a variety of different ways. And then the third thing we'll cover is very briefly what's coming down the pipe. What are we looking forward to as possible new states and new additions to this patchwork of laws that we're seeing? So if we can go to the next slide. Perfect. Thank you. So we'll start with paid sick leave. It is the messier of the two. Doesn't necessarily mean that it's more complicated, but the messier of the two setups. The paid sick leave landscape today, you can see in that column, the total mandates column, there are in the mid 50s, about 56 total paid sick leave laws scattered around the country today. Now, one thing that paid sick leave and paid family leave laws have in common, and there are many, many differences, but one thing that they do have in common is that there isn't a singular type of law under either umbrella. Paid sick leave laws are made up of paid sick leave, paid sick and safe time, paid safe time, the newest addition to this group, the mandatory PTO or paid any reason leave laws. You also have COVID leave laws, which are almost all gone except for one straggler in New York State that now has a sunset date 2 Julys from now. You have public health emergency leave and so forth. So the laws making up this number on this slide take all of those into consideration. Now, you also see at the bottom of that total mandate slide that rewind 3.5 years ago, the number of laws was close to 70. Now, the reason for this is that the landscape is constantly ebbing and flowing. A number of these COVID leave laws have sunset, as I mentioned a minute ago, but you also have developments where a new statewide law might come out and it could preempt local laws. Doesn't happen often. Didn't happen when Illinois passed its PTO law that went into effect on January 1st of this year. Didn't happen when Minnesota passed its statewide paid sick leave law that went into effect earlier this year on January 1st. But Duluth in Minnesota decided to voluntarily sunset its local law. So that created a little bit of an easier burden for folks in Duluth. Even though the number of sick leave laws today is lower than it was 3.5 years ago, it doesn't mean that there aren't frequent changes in the space. And that's one of the big things that's been happening. And what we're starting to see are laws not just being passed in new locations, but new types of laws being passed. I mentioned the PTO, paid any reason leave laws. You can see in that states column, the 19 states plus DC, Illinois, Maine, and Nevada are all falling to that group. We just saw Connecticut amend its paid sick leave law last year to add a mental health wellness day as a covered reason. New York just amended its paid sick leave law last month to add a paid prenatal leave bucket of time. First in the country to do that. It's 20 hours of paid prenatal leave on top of the paid sick leave that New York State already requires. That's starting in January of 2025. In about a month and a half, Chicago is going to have the country's first ever combo paid sick leave and PTO law, right? That one's starting up in a month and a half. The final rules just came out about a week ago. Lots of employers are struggling to implement changes to their policies and systems based on that requirement. So those are some of the changes in the paid sick leave landscape that we've seen. This is what it looks like today. If we go to the next slide, we'll see what the paid family leave landscape looks like. Not as many laws, but close, comparable to the number of states, right? It was 19 plus DC in the sick leave landscape. We have 13 plus DC in the paid family leave landscape. And as I said a minute ago, the paid family leave laws are coming out in a variety of different types and formulas as well. You have, as far as the mandates go, statutory disability insurance laws in 5 jurisdictions. And then you have paid family leave laws in 4 locations, all 4 of those states, California, New Jersey, New York, Rhode Island, that have a paid family leave law, also have a statutory disability insurance law to fill the gap, the missing medical component from their paid family leave programs, which are covered by the state's disability insurance program. And then you also have states and plus Washington, D.C. that have a paid family medical leave mandate. Lots of changes in this space as well. In just the last handful of months, we've seen Oregon's program come online. That was back in September. It was amended in some major ways just a few months ago in March, including how it coordinates with the state's unpaid family leave law, as well as how it coordinates with employer-provided paid leave, PTO, parental leave, short-term disability, and so forth. Colorado's program came online back in January. And we saw Maryland just amend its program to move back some of its effective dates because they're having a slightly harder time standing up some of the details of their program, giving themselves more of a runway. But we have 4 jurisdictions, Delaware, Maryland, Minnesota, and Maine, all with paid family leave laws that are coming online between now and mid-2026. So lots of activity in the paid family leave space as well. And if you go to the next slide, we'll see that the paid family leave space also has another wrinkle. It has these voluntary programs or these paid family leave being added as a class of insurance, which started in Virginia about 1.5 years ago. And now there's more than 6 states that have added paid family leave as a class of insurance. These are alternatives to the paid family leave mandates that I mentioned on the last slide. But what we're starting to see, even though these alternatives are out there, and Virginia is sort of the first test case on this, we haven't seen in the last 1.5 years a huge uptick as far as folks adding family leave as a class of insurance, as a private option. So that even though these could be signs of where paid family leave might be heading down the road, and certainly from political alignment, more of the red and maybe purple states would look to this as opposed to imposing a mandate on employers within their jurisdiction, this doesn't seem like the avenue that's going to satisfy the paid leave advocates that are pushing for paid leave in states. So we'll see where this one goes. It's certainly an option that has taken a large amount of growth in the last 1.5 years. Next slide, please. So that's the landscape. Those are the paid family leave laws, the paid sick leave laws. What we're left with in both settings is a patchwork of laws where each law has divergent characteristics from the other law. Now, this snapshot, which I'll get to in just a second, is an infographic that my firm, Seyfarth Shaw, and I and our team prepared with our friends at the American Benefits Council. We rolled it out last summer. We've used it in webinars and other marketing tools. Really useful snapshot of just 4 substantive topics across the paid family leave law spectrum. Each of the paid family leave laws and paid sick leave laws carries between 2 and 3 dozen substantive requirements. And as I mentioned, those requirements diverge from one another. There are variations across the board. What that leads to are challenges for both employers and their employees in terms of understanding what their benefits are, keeping up with the pace of change as these laws are being rolled out, implementing new policies, right? Revisiting policies that a lot of companies spend a lot of time and labor and thought leadership putting together, only to have those policies upended when a new law or 2 or 3 come out, or existing laws are tinkered with and changed, as I mentioned, has been happening in the paid sick leave space. Where you land as an employer is a hope that you can have a one-size-fits-all approach, right? Hope that preemption might come and save the day. Hope that you can get some level of equivalency or harmonization across these laws. And that just isn't what we're seeing. And that's especially true in the paid family leave space, because one of the big differences with paid family leave versus sick leave is that insurance component, right? These laws are very much designed comparably to workers' compensation and unemployment, with the state public program being in the mix or the alternative private plan route for employers to work with a carrier or third-party administrator to set up a private plan approval. But to get a private plan, approved, and that doesn't exist in every jurisdiction with paid family leave. Rhode Island and DC don't allow it. It's what the top box in that top right corner shows you there on the slide. In the states that do allow it, though, there are substantive criteria that have to be met. There are administrative criteria that have to be met. But on top of all of that, there's a commonality that says you have to provide equal or greater benefits than what our public program would provide. And because of differences in things like intermittent leave, definitions of family member and serious health condition, waiting periods, the covered reasons, the amounts of leave, how the pay is structured, how the coordination with company policies is operated, employers cannot set up a one-size-fits-all approach in these states. That is the fact of paid family leave today. And that's the Wild West, the alternative reality to what so many of you who deal with ERISA and are ERISA experts, this is the alternative to, had it not been 50 years of preemption and harmonization and uniformity, this is what we're left with. And again, so to point out just a few seconds on this patchwork graphic here, if we go to the next slide, please, it's a zoomed in version a bit. So this shows 4 categories. It shows the amount of leave that each of the laws provide across different categories of leave: medical, family, military, exigency, and caregiver leave, and then a category of other leave, right? These laws are more than just family member caregiving, bonding, my own serious health. They can also cover bereavement, bone marrow and organ donation, safe time domestic violence leave, public health emergency leave, and so forth. And you can see in that green column, some laws don't have any of those additional categories. Some have 1, some have 2, some have 3, depending on the jurisdiction, right? And that can impact how all these things interplay with company policies and other state laws. This graphic also shows you the percentage of wages being paid to employees and divergence there, the inability for employers to treat their workers equitably, even if they're performing the same role, same position, but just in a different state, right? The percentage of wage replacement varies from one state to the next, and in some places in significant percentages, right? Some at 60, 70%, some all the way up to 100%, like you see in Oregon. And that's not 100% full wage replacement. There are weekly maximum caps in each of these jurisdictions. And then finally, this graphic shows the differences in family members as well, non-immediate family members outside of parent, child, spouse, grandparent, grandchild, and sibling. A lot of these laws will go a step further. Many of them will cover someone who's the equivalent of a family member as well, which leads to complications day to day for companies to administer. So what these complications result in, as I said a minute ago, are challenges on employers from a policies perspective, from a programming perspective, getting their HRIS, payroll, and timekeeping systems up to date, training their managers and their HR how to administer these benefits on a day-to-day, and then getting all of that information out to their employees in terms of how their leave operates, how they can coordinate it with the company-provided benefits. Next slide, please. So what's coming next? Paid sick leave landscape. This is just a quick snapshot. I mentioned the top half of bullet points already, some of those developments that we've seen. The New York state paid prenatal leave, also amendments to Connecticut's law that are just being passed actively right now. We're waiting for Governor Lamont to sign the legislation, but it's expected in the coming days. But the bottom set of bullet points, right? So federally, seems unlikely that we're going to have a federal paid sick leave mandate at any time in the next 2, 3, 4 years, and certainly that it would do anything to resolve this patchwork of laws. Right, the focus federally really is on paid family leave, paid family medical leave, as we'll talk about on the next slide for just a second. At the state level, though, a lot of potential. Delaware, which passed a paid family medical leave program last year, is pushing very hard to get sick leave across the finish line this legislative session. There are ballot initiatives going on in both Nebraska and Missouri for this upcoming election in several months. Historically, if a paid family leave mandate makes it onto the ballot, it passes. So keep a very close eye on those 2 jurisdictions. And there's also some good activity going on in other places like Virginia, where there is a statewide mandate, but only impacting certain home healthcare workers. Could that be expanded to all private employers, and other jurisdictions like Hawaii and Pennsylvania as well? Municipalities, pay attention to New York. They might do something like what I spoke about for Chicago a few minutes ago, adding a PTO personal time law on top of the city's paid sick leave law. Next slide, please. So finally, we have the paid family leave landscape. What's coming next? Some good news, I suppose, in the middle of all the doom and gloom I've been talking about so far, is that 3 jurisdictions that came very close to passing paid family leave this session, New Mexico, Hawaii, and Virginia, all fell short for various reasons. So we expect those jurisdictions to all try again next session. They've been trying for the last several years. it is likely that one of them will squeak through, as well as places like Michigan, Illinois, and Vermont. Federally, some of you might have heard that there are working groups in both the House and the Senate that are actively studying paid leave. The House in particular has been incredibly active. Representatives Houlihan and Bice have been having thought leadership sessions and meetings with various stakeholders, with carriers, large employers, small employers, employee advocates, the existing states, right, collecting data and information. They released a policy framework for federal paid leave back in January. And one of the very big focal points of that policy framework is something called the I-Plan, the Interstate Paid Leave Action Network. There's no legislation yet, but the focus of that, the core goal is harmonization of the existing patchwork of paid leave laws. We're optimistic on the prospects for the I-Plan. The American Benefits Council is playing a very large role in trying to push that initiative forward. And that's where things stand today. Sure, if I have a minute or two for questions, but thank you everyone for your time.
Hi, Carl Polzer, Center on Capital and Social Equity. I'm advocate for low-income workers, and I believe in 5 sick days for all workers, because if you want, everybody here assumes sick, they get sick leave. If you go to I used to work for the long-term care industry. If you go to one of their meetings of their workers, 25 or 30%, they have to take a pay cut to go to the doctor if they have insurance. Okay, so what this lack of uniformity that you describe in sick leave laws leads us to one of 3 ERISA type conclusions. One would be total preemption, sort of it's employee benefit should get out. One would be a HIPAA-like floor, where the federal government would set a floor and hold harmless for employers if you do that, and let states add some things. And the other would be, you know, some kind of national standard, totally federal. What would you prefer? I mean, where do you see? I mean, I know in the next few years we're not going there, but there seems to be momentum. What would you prefer?
Yeah, well, preference is a tricky question, right? What do I expect? I expect that the federal government could step in, right? They've been trying for a few years with the Healthy Families Act. There is Executive Order 13706, which has a paid sick leave mandate for certain contractors and subcontractors with the federal government. So they've been using that as a model to try to build paid sick leave off of that. But it doesn't seem as if there's going to be any level of preemption, right? What I would prefer is that there becomes a greater level of uniformity and consistency across the states, that they get to a point where the covered reasons, the amounts of leave, the usage characteristics, the rate of pay, that gets harmonized. I don't expect that'll happen. I think the most likely outcome is we continue with the Wild West that we have today, or we get that second option where the federal government sets a floor, but doesn't end up doing anything to preempt the states from going further up. Yeah, thanks. Thank you, everyone.
Thanks, Josh. That was great. Jake and I only have about 10 minutes. And while he makes his way up here, I wanted to get us started. When Jim Klein and his team at the council met with the EBRI team months ago to brainstorm what we could do together in recognition of EBRI's anniversary, we all came up with the idea of doing focus group-like meetings with employers to get their point of view on ERISA preemption. Jim and his team get the credit for pulling together about a dozen large employers, and we met with them back in February during 2 meetings. We asked them questions such as, what does ERISA preemption mean to your company as a sponsor of health benefits? Can you give examples of how ERISA preemption has allowed your company to be more innovative as a sponsor of health benefits? Can you give examples of how ERISA preemption has enabled better management of health benefit costs? What would you do differently, if anything, if ERISA preemption disappeared? Any aspects of ERISA preemption that are problematic or you wish could be changed? What is the value in continuing to offer health benefits in a traditional way instead of doing things like moving to an individual coverage health reimbursement arrangement, or private health insurance exchanges, or just dropping coverage altogether and letting your employees get coverage through the Affordable Care Act? We asked some other questions as well. The companies we could go to the next slide. The companies we talked to not necessarily nationally representative, but they're large, and I would describe them as leaders. They would trigger a trend or set a new trend, and they were wide-ranging industries. Each firm employed at least 25,000 employees, plus dependents. They had at least 500,000 covered lives and collectively spent over $6 billion on health benefits. So before I turn over to Jake to tell us more about what we learned from the conversations, I just want to thank Jim and his team. They did a lot of the heavy lifting, and the project was a lot of fun to work on. So be on the look for an issue brief from EBRI in the next month or two with our findings, and I'll turn over to Jake to tell us more about what we found.
Thanks, Paul. Excuse me. You could be the most diligent researcher, the most competent, the most thorough researcher, but there's just no substitute for the views and experiences of those with the boots on the ground. And so we learned a lot from these discussions with benefits executives at large companies. I would say that we were almost bombarded with insights, and it was no small feat to distill those insights into a white paper. But in doing so, we identified three main themes. The first theme that we came across on the next slide is a consistent menu of benefits and a consistent landscape of regulations. So under ERISA preemption for self-insured employers, there's a uniform landscape of regulations that employers have to adhere to. And so employers were drawn to the ability to have equal benefits regardless of where people sit. And this is becoming an increasingly important thing now that remote work is more widespread. And so this benefits equality piece was very important to employers. One had said that they have a strong desire for everybody to have equal benefits regardless of where they sit. And another had said something about the equity piece being very important to them. They wanted their employees in California and Colorado and New Jersey to all have the same benefits. If they got different benefits, that's not equal, and that's a situation that they would prefer to avoid. And another benefits executive even highlighted that they viewed ERISA preemption as lowering barriers to talent mobility. And by that, they mean, if there's an employee in Oklahoma and they get a promotion and they get a chance to move to maybe headquarters in California, the employer knows that because of ERISA preemption, that the differing benefits in different states won't be part of that decision about whether or not that person chooses to move across state lines to go work in headquarters. The second theme that we discovered was that of innovation. And namely that ERISA preemption fosters innovation. One even went so far as to say that ERISA is the path to innovation. So each employer has a different workforce with different needs. A largely blue-collar old workforce in Kentucky is going to face different issues than a young white-collar tech workforce in California. And so employers want to have the flexibility and freedom to offer benefits that target that have a laser target on their particular workforces. One employer went so far as to say that going to a 50-state patchwork solution is actually the opposite of innovative, which I find pretty sympathetic. And just to add on to that, a third one said that a lot of innovation comes from point solutions that help employees live healthier and better lives. And by point solutions, they mean things like diabetes management, mental health issues, weight loss management, and those things aren't going to be relevant to every single workforce, but employers want the ability to tailor benefits that best help their workforce live healthier and better lives. And the third theme that emerged was that of the ability to offer high quality and relatively low cost health benefits. Employers called out the fact that ERISA preemption was the framework that allowed them to actually deliver high quality and relatively low cost health benefits to their workforce. And the way that they realize those savings comes in two channels. One is that employers would have to really staff up if they had to manage 50 different state benefits instead of just one uniform federal standard. So one said that they have to double their staff or hire more consultants to help manage those complexities, and those costs are going to add up and get passed along to employees. Another channel that employers realize cost savings from ERISA preemption is being able to negotiate with the same provider across state lines. So one noted that in particular on the pharmacy benefit manager side, if they had to negotiate with a different vendor in each state, that would sort of negate their ability to leverage their size to negotiate better benefits and better prices for their employees. And so when you lose that control by having to go with a number of different providers, it's going to end up costing more, and most likely those costs are going to get passed along to employees. And so, as Paul mentioned, these insights and many more form the backbone of a white paper that is forthcoming. So please be on the lookout for that in the next month or so. And now I believe I'm going to kick it back over to Paul as he and a special guest engage on a nice, cozy fireside chat on this warm and sunny 80-degree afternoon.
Okay, so my pleasure to be up here with Dr. Douglas Holtz-Eakin for this fireside chat. Dr. Holtz-Eakin is the president and founder of the American Action Forum. Doug has also served in a variety of influential policy positions, some I'm going to mention. During 2001 and 2002, he was the chief economist of the President's Council of Economic Advisors. From 2003 to 2005, he was the 6th director of the Congressional Budget Office. And it was during his tenure at CBO that CBO assisted Congress as they addressed numerous policies. I'm just going to note one. Do you know which one I'm going to note?
Medicare.
The 2003 Medicare Modernization Act.
Never goes away.
Which also gave us HSAs. And the reason why I want to mention this is because during 2003, that's when we met for the first time. I don't know if you remember this conversation either. Dallas may remember it. Dallas and I had just published a paper. It was entitled, "How Many Medicare Beneficiaries Will Lose Employment-Based Retiree Health Benefits If Medicare Covers Outpatient Prescription Drugs?" Right, quite the mouthful. And when Doug's CBO did their estimate, they came out with 31 to 37%. Dallas and I came out with 2 to 9%. And needless to say, the first thing Doug ever said to me, I think Dallas was part of this conversation too, was something like, "That paper you wrote has caused me more problems than anything I've ever had to deal with at the CBO." After Doug left the CBO, he was director of domestic and economic policy for the John McCain presidential campaign.
Not my fault.
Not your fault. And after that, he was a commissioner on the congressionally chartered Financial Crisis Inquiry Commission. So Doug, thank you so much for joining us today.
Thank you.
So we just have a little bit, we should have more than 2 minutes left though.
I've been marked to market again.
So first question, employers. I didn't think my introduction was that long. Employers complain about increasing premiums, variation in quality of medical services, the price of hospitals, price of prescription drugs, lack of transparency. And we could go on and spend the rest of the afternoon just, airing grievances. Yet you think the greatest threat to health benefits is not any of those issues, nor I think public policy proposals that we've seen like single payer, but in quotes, the slow erosion of ERISA preemption at the state level. Can you talk more about your thinking behind this?
Sure. Well, first of all, thanks for talking to me again after 20 years. This sort of lies at the intersection of a lot of things that are going. And so, first of all, outside of this illustrious group, not a lot of people pay attention to ERISA. Many people don't even know it's there. They don't understand what an important achievement it was 50 years ago. And so when we sort of have gone through the debates over coverage, expansion of coverage, universal coverage, Medicare for all, they're not focused on keeping the coverage we have, which is in fact the ESI coverage, which is the majority of people in the United States, and ERISA being 60-odd% of the folks in ESI. So the first thing we want to do is not lose a lot of coverage, and that's been the central debate for a while now. The second broad theme that gets my attention is that we've now shifted from a coverage debate to a cost debate. Both parties talking about cost of healthcare, focusing on particular pieces of it like drugs a lot, but more generally, ERISA was a way to get lower cost healthcare because you can take advantage of economies of scale that came up in your employer's survey. If you've got nationally traded goods and services, you should have a national market for those goods and services. ERISA provides a national market. It lowers the costs of compliance. That also came up in the employer survey. So it's central to sort of doing what you can in health plan design to keep the cost down. And then the third thing that has me concerned is that we're seeing in this area, as in many others in public policy, that policymaking is being done by the courts, and the Congress is not stepping up and saying, okay, it's been 50 years. What do we want to do? What's the direction this nation should take? And I don't like that because we're getting these piecemeal decisions that undercut the basic premise of ERISA.
Policymaking has also been happening at state level.
Yes.
Do you have any thoughts on what large employers can do to address what's happening at state level?
Well, they're already doing it. I mean, they can go in and make their case with state policymakers and state leaders and say, you know, I think you're going to do more damage than good with this. I mean, these policymakers have the best of intentions. No one should be confused about that, but they're going to damage location decisions. And people don't think of that when they think about employee benefits. But if you don't want to have to comply with that state mandate, then the next decision might go to another state that's honoring the ERISA intent. So make the case that this is a piece of the attractive location decision that most firms have to make, and they're hurting their case.
So the employer role in providing health benefits has been debated back and forth between the left and the right. Do you have any thoughts on the value that employment-based coverage provides in the context of the entire healthcare system?
So this is a very close to home question, since I was the guy who, on behalf of John McCain, proposed blowing up employer-sponsored health insurance. That experience has made me a raging incrementalist, and it's an incredibly valuable benefit. And in the context of the health insurance system, from the sort of more conservative point of view, it is work related, and you want to have all benefits that you can be related to work and get people into the satisfaction of working and the advancement that it brings. This fits right in with that, and it is the most prominent source of coverage. It's a tool that employers use to attract high quality workforces. All of that's true, and I think, you know, the public is not willing to leap into something new until they're convinced that it works, and so they're sold on the employer-sponsored insurance system.
So there will be time for questions. So think about what you might want to ask Doug related to your, would you say, raging incrementalist?
Yes.
You know, the tax treatment of health benefits
Yep.
has come under attack, both from the left and the right. And economists have argued that it's inflationary, it's inefficient and regressive, which is one reason why many were against repealing the Cadillac tax. I think at the time you also supported, you were also against repealing the Cadillac tax. How have your thoughts about that have changed, whether it's in an incremental way or a non-incremental way?
So the Cadillac tax was just a disguised way of repealing the exemption from tax of ESI, or capping the exemption, or any number of those things. I still have a belief that we ought to think about doing that in the following sense. The federal government subsidizes every piece of health insurance. It subsidizes ESI, it subsidizes the ACA, it subsidizes Medicaid, it subsidizes Medicare, veterans, TRICARE. You know, everywhere you look, there's a subsidy, and it's the most uncoordinated, inefficient set of subsidies that you could imagine. And so we throw some money in the ACA, do better premium tax credits, pull people out of the small group market and employers, and then they go away and they go back to the other one. And so I would like to see that set of subsidies rationalized. You may or may not have noticed that we have some budget problems on the horizon, and there is going to be an increasing need to spend our taxpayer dollars more wisely, and rationalizing those subsidies would be part of it. That would probably mean capping for high income individuals the exemption for ESR.
So we heard, I don't know if you were here this morning, but the opening panel had mentioned some of the people in Congress that were part of, you know, when ERISA passed, Jacob Javits and others. Do you see anyone up on the Hill who could be a champion for ERISA?
Well, we've had hearings on this, so, you know, it's not that it hasn't gotten noticed in the committees of jurisdiction, I think that's the natural place to look. This has not been a policy heavy Congress, and with age comes a little restraint.
You're not trying to be funny, right?
Yeah, so I'm hoping next Congress, we get a little more momentum on the policy front.
So a couple of years ago, there was a survey of large employers which found that 86% expected the government will be required to intervene to provide coverage and contain costs. And I was kind of astounded by this finding that 85% are looking to the federal government to intervene on coverage and costs. And when Jake and I talked to many large employers about it, we pushed them to be specific, even though they weren't necessarily part of that survey, but to be specific about, what they could get behind. And the only thing that came out of that discussion was government regulation of prescription drugs. It's the only thing anybody could think of off the cuff without it being given a list. I'm not surprised that the cost of specialty medications and gene therapy are keeping employers up at night. You've got traditional PBMs, the more transparent PBMs are around now, and now Mark Cuban has a business that has started working with employers. Do you have any thoughts on how to create a more viable free market and what might have the most influence in this space?
I don't have any that I'm going to pretend are so close to the finish line we can just push them over and have big success. This has been this is something I've spent the past 20 years on with not a great amount of success, to be honest. One of the things I would love to see is for the various private sector players to stop appealing to the government to get that other guy and instead get together and come up with some private sector solutions. I think it's long past time when the PBMs and the manufacturers and the insurers sat down and figured out how they're going to cover specialty drugs and some very narrow, very expensive right now oncology and increasingly other kinds of medications. We spend and the reality is that the drugs have taken all the oxygen out of the room, and the bulk of the money is still spent on hospitals and docs. And we have to get our hands around the whole problem and not just the rifle shot.
Okay. Last question, and I'm going to open it up to all of you for a few minutes. Large group market works fairly well at providing health benefits, but small group market has its challenges: lower offer rates, higher rates of uninsured, among other things, affordability. Anything you can say from your days at CBO or now about, what we might be able to do to improve the small group market?
I think, the problem with the small group market is it's small, and anything that gets you enhanced pooling ability makes it bigger is the route. And it's also not a particularly knowledgeable crowd. You talk to the folks in the big employers, they have benefits managers and they have consultants, and they're well versed, they know their options, they shop well. I think we have to somehow really help the small business flags with an education campaign on providing better.
We have time for 2 or 3 questions. There are mics floating around. If anyone has a question, please raise your hand and we'll get a microphone over to you.
Hello. There it is. Thanks, guys, for the good discussion. I agree, Doug, what you just mentioned about, like, it's not just about going out and getting the other guy, but finding solutions. And us as employers have to be willing. Sometimes we're not very good at change, and actually stepping up and say, there are actually solutions out there and we're going to utilize them because we're tired of the status quo. I think we can all do a better job at that. The one thing I will say, though, I think is that will help with that and infuse some of that is continuing the transparency work. Like, good start. We need more of it, particularly on quality transparency. Like, I'm continually frustrated when we go to some of our partners and ask for quality transparency on things like, who's the top quality doctors? Don't tell me about the system level. Tell me at the individual doc level, and getting that. And so I think that could create more of a market, a freer, open exchange of market where we can feel good about. If we had transparency, we could make better choices. What are your thoughts on that?
So everyone should like to have transparency in the sense of knowing what you're buying at what price and being able to comparison shop and all that. I get nervous about the transparency discussion when it moves into the legislative arena, because it's often opening private contracts, which I am not a big fan of. There there is the sanctity of private contracts. I think it's an important part of the free enterprise system, and we have become a little bit cavalier about that. So that's a concern about where that goes. The quality thing is a particular frustration. We are now overwhelmed with quality metrics. We have so many quality metrics, we have no idea who's any good. And there has to be an effort to sort of find a very simple set of metrics, some of which are outcome metrics, some of which are process metrics. Make that list short enough that a real person can read it and disseminate it widely. That's missing somehow. Yeah.
I think we have time for one. We could squeeze one more question if there are any. Okay, well, thank you so much, Doug. Really
Thank you.
appreciate you being here. So it's about 2:15, just in time for our afternoon break. I just want to thank all of our speakers for their thoughtful insight and participation. Thank all of you here in person and everyone attending online. Just a few instructions as we go into the break. The live stream is going to conclude. We appreciate everyone's online participation, and we will be sending out to everyone in a day or so the link to view our live streamed event.